All right, good morning, everybody. Welcome to Pediatric Grand Rounds. This week's Grand Rounds is featuring our QI program and our QI scholars. And I am going to turn things over to Dr. Lori Rutman, who's going to introduce our speakers for today. Thanks, everybody.
Good morning, everyone. Thank you for your participation today. My name is Lori Rutman, and I'm Program Director for the Quality Improvement Scholars Program. Today, I'll be giving a brief overview of the program and introducing the 2019-2020 scholars. Each scholar is going to present the project that they've been working on, and then we'll have about 10 minutes at the end for questions on the projects and also about the program. So please hold your questions and comments until then. QI Scholars began in 2015 to increase faculty expertise related to the rigorous evaluation of the quality improvement activities in the Department of Pediatrics at Seattle Children's Hospital. There are three components to the program: the QI Research Project, monthly seminar attendance, and participation in works in progress sessions. When the program begins every October, each scholar is paired with a mentor who's experienced in QI research methodologies. They meet twice each month to work on project design, identify data needed to complete a project, and then they work with the clinical analytics and Bear Core to obtain the data they need. The mentor and scholar work together to interpret data analyses that's received from their statistical team, and eventually they work together to draft and submit a manuscript based on the results. QI Scholars has multiple experienced statisticians on our program faculty, and each scholar is paired with a statistician and data analyst with whom they meet monthly as needed to address any analytic or programming needs for the scholar's project. Each scholar is also provided with project funds to support research assistants, data analysts, statisticians, and other related costs. Given the challenges of research projects, most scholars are unable to complete their project within the first year, so we have an automatic one-year extension for the use of their project funds. Our program faculty are listed here. Again, one of the real strengths of our program is the dedicated support that each scholar receives to both maximize learning and make their projects a success. Our monthly seminar series makes up the program's didactic sessions on state-of-the-art QI research methods. Seminar attendance is required for the scholars, but we also have a few spots in every session for those who are interested in auditing, and this can be great opportunities for residents or fellows who are really interested in learning some QI methods, but are not yet at a point where they can take the full curriculum. Currently, 9 of the seminars are given by outside speakers from institutions such as Cincinnati Children's, the University of Michigan, the Harvard School of Public Health, and Kaiser Permanente Washington Health Research Institute. 3 of the seminars are given by UW Department of Pediatrics faculty. The seminars are generally on Tuesdays from 9 to 1, usually the first or second Tuesday of the month, depending on speaker availability. So each seminar is 4 hours, of which less than half is lecture, and then there's a lot of interactive exercises to teach the scholars how to apply the material that they're learning to their own work. This year, the series usually begins with QI fundamentals, though COVID threw off our schedule a bit. After QI fundamentals, we have an introduction to statistical process control, anatomy of a quality measure, assessing and improving disparities in quality improvement research methods, driver diagrams and the Squire guidelines, which is a split session this year, interrupted time series analysis in QI research, health economics and QI supply, demand and value, decision analysis, an introduction to implementation science, survey development for QI research, qualitative methods in QI research, and context in quality improvement research. The readings for all these sessions are available before and after the seminars, as well as all the slide presentations if the scholars need them for reference. The final component of the program are the works in progress sessions. QI Scholars holds quarterly meetings in December, March, June, and September with all program faculty and scholars. At these meetings, the scholars present their work to date, and they get feedback from their peers, the other mentors, and the program faculty, which really allows for troubleshooting and brainstorming any unique project challenges they've encountered. They're encouraged also to participate in the monthly QI and Outcomes WIPs. These typically fall on the 4th Wednesday of every month at 2 p.m. in FA 2110. At these WIPs, a wide range of QI research is presented, ranging from grant proposals to fellowship research projects to hospital QI work. Each year, November and December are reserved for QI scholars to present to a different audience, and to start preparing their presentation at Grand Rounds in the spring of their second year. So there will be some exciting changes to the program for this next upcoming year. First, we're thrilled to welcome new scholars and faculty from UW Medicine. This new cohort will join our children's scholars for the seminar series and works in progress sessions, and we're really excited for the opportunity for greater collaboration and learning across the broader health system. On the children's side of the program, we'll again have up to 4 scholar spots for assistant or associate professors in the clinician scholar or academic clinician tracks. Professors will be considered on a case-by-case basis. Also new for the upcoming year, we'll be opening the program to all departments represented at Children's. And finally, we'll have up to 1 scholar spot available for leaders from our Center for Quality and Patient Safety. All scholars must be able to commit to 1 year at a minimum of 10% protected FTE. The FTE commitment will be covered by the scholar's home department as a release from clinical obligations. A letter of commitment from the department chair and division chief, where applicable, is also required as a part of the application process. And we really focus on this mandated release from clinical activities because attendance at our meetings, seminars, and WIPs is essential to the success of the program. Scholars really need the time to be able to do the coursework that's a part of this program. In order to expand mentoring opportunities across the hospital and within the department, we're also asking that applicants in future years be willing to serve as a mentor for a future class of scholars if they're selected. So there will be a competitive process to increase our pool of available mentors in the program. This will require a 5% FTE commitment, which will be paid for by the program. So now in its 6th year, QI Scholars has reached 13 different subspecialties. We're really proud of how many different divisions we've been able to reach at the hospital. And here are some key dates for the upcoming program cycle if you're interested in applying, and I hope you will. The program announcement and requests for applications go out on July 1st. Applications are due around August 6th, and the scholars are announced by early September. The kickoff meeting will be in early October with the first seminar shortly thereafter, and then the program end date is September 30th with, again, as I mentioned earlier, a 1-year extension for use of the project funds. We do have a site on Child under Research Centers and Programs, QI Scholars, where you can view the current scholars, program faculty, and see all of the amazing work that our program alumni have accomplished. But now, without further ado, the reason that you're really here today, I would love to introduce the scholars who are going to present today. Emily Hartford will go first. Emily is an assistant professor in the Department of Emergency Medicine. Joy Kawamura is an acting assistant professor of psychiatry and behavioral sciences and also has a position in gastroenterology. Lindsay Morgan is an assistant professor in neurology. And Jessica Warner Grant is an assistant professor in hospital medicine.
Good morning, everybody. Super happy to be here. And I was really thrilled to be a part of QI Scholars over the last couple of years, and especially part of this cohort back when we used to meet in person even. We started in 2019, so our first few sessions were pre-COVID. I'm going to talk to you today about my project on improving interpretation in the emergency department for families who prefer a language other than English, and I have no disclosures. So the global aim of this project has been to increase the use of interpretation for families who prefer a language other than English in our emergency department. We're transitioning our terminology, and you'll hear me go back and forth a little bit as I'm still getting used to it. But we ask families about language preference. We do not assess their proficiency. And so we're trying to transition more to language other than English rather than limited English proficiency. The ways that we've been working on this have been to identify and address barriers to interpreter use in our setting, to provide education and data feedback to our care teams about how we're doing with interpretation, and also to gather perspectives from families who have limited English proficiency. So about 9% of the US population, according to our last census in 2015, and we'll have updated numbers soon, have limited English proficiency, and that means they answer on the census question that they speak English less than very well. But about 16% of kids live in a family who has limited English proficiency. And this has been growing over time. And this is reflected in our emergency room and across our hospital, where about 16% of visits have a family who prefers a language other than English. And this is the language breakdown in our ED. So that the turquoise bar there is Spanish. About 60% of our patients are speaking Spanish if they speak a language other than English. But then we have a quite diverse array of languages after that, which is kind of fun. We get to hear Somali, Vietnamese, Amharic, Cantonese, Mandarin, Arabic, Tigrinya, Oromo, Russian. And then that yellow bar there is all others. So that's just a whole bunch of other languages that make up less than 1%. So there's quite a variety. And really the impetus and sort of, motivation for this work is we know that families who have a preferred language other than English face enormous inequities in their care. This is just a sampling of what we see in the literature, what different examples of what has been shown as inequities in care for families with limited English proficiency or with a language other than English. They receive different tests and interventions when they see us, and I'll give you a few examples in these studies below. For families who present with gastroenteritis, for example, the child, if they have a language other than English and they have a language discordant provider, so somebody who does not speak that language, they're more likely to get admitted, more likely to get more testing done, IV fluids. Whereas if they have a bilingual provider that they're seeing, there are no differences between their care and those who are English proficient. Another example is for kids who present with signs, and you can go back a slide. I'm going to talk about this one for a little bit. Kids who present with clinical syndrome that looks like it could be appendicitis, who have very similar clinical findings on their exam and on their history. If they have a limited English proficiency, they're less likely to get a CT or ultrasound ordered. And we know that those kids are also more likely to present with perforated appendicitis when they do present. So is it that they presented later, or is it that we missed it on the first visit? And then more recently, there was a big study on looking at bronchiolitis guideline concordance for families who speak another language. And if they had a language other than English, they were more likely to get chest x-rays, blood cultures, labs, things that are not concordant with our bronchiolitis guidelines. And a work done here a little while back now, a case control study in our hospital, patients who were Spanish speaking were twice as likely to have serious adverse events during their hospitalization. And also another study done here at Seattle Children's, post-operative patients were less likely to have pain treated. So for the same pain scores, they were less likely to get opiate pain medications. When they did have interpretation, those differences improved. So that is some bit of good news there. We know families with a language other than English are more likely to have return visits to the ED and get admitted, which is a really important quality marker for us. And children with chronic needs have lower access to services, lower medical homes and insurance. And we know that families also have longer ED and hospital length of stay. So there are many examples of the inequities these families face. And the good news is that professional interpretation can help. On the next slide is a study we published in 2019 showing that unfortunately professional interpretation has been underutilized in many settings. And this is in our ED. This is the proportion of families who received any interpretation during their visit. For all of the families who had a language other than English, it was 45%. And then you can see the language breakdown as you go through the bar graph there. Interpretation use was less likely if the visits were lower acuity, if the patients came at a busier time of day for older patients. So this implies that perhaps we're relying on the patient for communication instead of providing interpretation to the parents. And then for certain languages, you can see there's really big differences there between Somali and Amharic compared to Cantonese or Spanish. So the specific aim for my QI Scholars project, which I was so happy to have the QI Scholars support in working on, was to increase the proportion of patients with a language other than English who receive interpretation in our ED to 80% within 1 year. Additional aims were to look at the wait times for families once they arrive to an ED room and they're assigned a nurse or provider. And then still working on this now is to gather patient and family perspectives as a guide of how we can continue to improve. The specific outcomes we've been following are the proportion of encounters that have any interpreter use and also interpreter use at different points in the visit. So we want to know, are we using interpretation more in general throughout the visit, not just are we using it yes or no? And this is a list of the improvements that we've made to date. There's a large team of people who've been working on this, and it's been my privilege to be a part of it. I'll show you at the end a list of the many names of people working on this. But we've tried to reinforce our universal screening for language preference. So everyone who walks in the door, every time we ask, what's your preferred language for care today, without making assumptions of what language they might want to speak. And then if they answer a language other than English, we follow up with, can we provide interpretation? We try to make sure families know it's free, it's readily available, and it's not something that that we try to reduce the barriers to using it. When they say yes, we have a color-coded sticker that goes on their patient label, so Spanish or Cantonese, whatever the language might be. And when they go into a patient room, there's a door sign that gets flipped to their preferred language as sort of a reminder to the team that they would prefer a different language. We have more video units. Thank you to Interpreter Services and our division. We've gone from 4, where we used to be running around the ED trying to track one down, up to 12, and now basically one in every room. So that makes it much easier to just get the interpreter on every time you walk in. They've improved connectivity, working with IT to make sure we have a dedicated network that supports the video calls when there are multiple happening at the same time. We've changed vendors. We have a great new vendor that has a lot of great professional interpreters. And we do a lot of data auditing, staff communication, safety stories, try to sort of keep it at the forefront of our awareness that we have to do a little extra work to communicate well with these families. This is an example of what the ED room looks like. So there's the preferred language sign on the door. There's one on every door, so it says English if you're English, if that's your preferred language. And then that's just a screenshot of the iPad tablets that we use for interpretation most of the time. These are preliminary results. We still don't have data that has been analyzed yet for this whole last couple of years, but this is our Tableau dashboard, and we use this regularly to evaluate how we're doing, to provide that feedback to providers, to look for dips so that we can see what's happening and try to improve it again. And you can see there's a slow uptick over time. This is 2017 to present, and we're hovering around about 75% of encounters receiving interpretation. And then another that you'll remember, one of the additional aims was to look at the wait times for these families. So this is another study that we've completed, looking at wait times for families with language other than English after they arrive to an ED room compared to English proficient families. And we did a retrospective cohort design for this one, the time from arrival to the room to the time that a nurse provider signs up for them, and the time that the provider or attending walks into the room. We controlled these findings for ED volumes, how busy the ED was, and also the acuity of the patient. We found that patients with a language other than English waited longer at every step in their care. And the next slide is just a visual of that. So the light blue are English-speaking patients, and the dark blue are patients who have a language other than English. And those are the 5 steps of care that we looked at. So this is the time that the nurse signs up for them, that the provider signs up for them, that the provider walks into the room. And at each point in their care, it's a few minutes difference, statistically significant, even when we controlled for acuity and ED volumes. And then this project I'm really excited about. It's ongoing. We're asking families what they want for interpretation and how they want to tell us, because we know there are a lot of differences in how families interact with interpretation, whether they say they have a preferred language other than English and then sometimes seem that they don't want interpretation. We want to know from them, how does this differ by language type, by culture background, by language ability? How does this differ for the perceived severity of the visit? Like if it's something like a cough or a cold versus, abdominal pain, does that change it versus mental health? How does it depend on which caregivers are present? So if grandma's there or an aunt or a dad, is it different? And would they want more control of interpreter usage? Should we be handing them a tablet where they can call the interpreter whenever they need it? This is a mixed method study. We're enrolling families right now in the ED, surveying them at discharge or right after discharge and following up with some interviews. So just a brief reminder, if you haven't seen this before, that equality and equity are different, and that equity requires us to do a little bit more for patients who come to us with a disadvantage, with being at risk for receiving inequitable care. And the next slide is a large list of people who've been working on this together, who I'm so thankful for their input and ongoing work and support. So thank you to the QI Scholars Program for this opportunity, and I look forward to continuing to work on all this together.
My name is Joy Kawamura, and I'm a clinical psychologist here at Seattle Children's. And as Lori mentioned, I am embedded within the Department of Gastroenterology and Hepatology. And I'm really thrilled this morning to be able to speak to you about my QI Scholars project, which was really focused on implementing routine psychosocial screening for youth with inflammatory bowel disease. I have no disclosures. And I like to start with a little bit of background. So, as I mentioned, I work with many different patients and patient populations within the Department of GI. And one of those populations involves youth with inflammatory bowel disease, which is a chronic illness that is most commonly diagnosed in adolescence and young adulthood. And extensive research has really demonstrated that youth with IBD report higher rates of depression and anxiety, lower quality of life, and poorer family, social, and academic functioning. Other studies have shown that families of these youth with IBD are also at increased risk of of psychosocial distress and dysfunction. And because of that, the National Association for GI, Pediatric GI recommends that we are monitoring psychosocial functioning in these domains as part of routine clinical care. So, what sorts of psychosocial resources might be helpful for these families? Well, of course, we know that mental health therapy, and that could be individual or group intervention, can be helpful for these patients and their families. Our social workers are incredibly important in terms of providing support for families and advocating for these kids within their schools, as well as other settings that they might be encountering some challenges within in our communities. We know that children with chronic illnesses really benefit from 504 plans in schools, and these plans make sure that they're receiving the accommodations that they need to be able to succeed academically despite medical needs that they may have. So, for children with IBD, this may be extended time on tests. This may be excused absences for doctor's appointments, really things that we think are going to set them up for success and make sure that their IBD diagnosis or treatment is not putting them at a disadvantage in those settings. And finally, we know that not just families with IBD, but many of our families that we care for have other concrete needs that resources may be beneficial for in terms of addressing food insecurity, housing insecurity, and challenges with attaining consistent and reliable transportation. The problem, though, is, and this is not specific to Seattle Children's, but psychosocial resources are just really limited. So, here within Seattle Children's, in the Division of GI, there is one psychologist, which is me, and one social worker that is dedicated to kind of the general GI group, and IBD kind of falls within that. And that certainly is not enough to be able to provide a full psychological evaluation and intensive services to every patient that we are seeing. And we also know that not every patient needs that level of care. And so, one approach to be able to increase access to the right level of care for patients and their families is to use routine screening to stratify families by level of psychosocial risk to make sure that the level of intervention that they're receiving is commensurate to kind of what their needs are. The model that you see on the right is the Pediatric Psychosocial Preventative Health Model, which was developed by Ann Kazak and her colleagues, really within an oncology population, but has been generalized to other pediatric subspecialties as well, and uses kind of a broad psychosocial screening approach to be able to quantify what kinds of resources and what level of resources families would need. And so, thinking about using routine screening to help guide, using data, guide families to the right level of resources is one way of improving equitable access to limited psychosocial resources. So, the goal of my QI Scholars project was really twofold. So, one was to implement psychosocial screening using the psychosocial assessment tool, or the PAP 2.0, as a part of routine care for newly diagnosed IBD patients. And the second was to determine whether routine screening leads to a higher percentage of patients being connected with appropriate psychosocial services and resources. I had two process measures that I was looking at. The first was the percentage of newly diagnosed patients who were seen by a GI psychologist or social worker, as indicated and documented within our electronic health record within 3 months of being seen for the first time within our Seattle Children's IBD Center. And the second was the percentage of patients with a documented 504 plan or other appropriate school accommodations. So this key driver diagram really outlines my thinking and kind of guided the way that I carried out my project. So the overall aim for my project was to increase the percentage of patients who were seen by a psychosocial provider within 3 months of diagnosis to 80% within the first 6 months of implementing psychosocial screening. And the drivers that I was really focusing on here were really focused on the referral process to the psychosocial providers, and knowing that that is a limited resource. And the idea that I focused on was implementation of routine psychosocial screening. If we dive in a little bit deeper just on that orange pathway, the sub-aim then would then be to complete psychosocial screening of 80% of patients who are newly diagnosed with IBD within 3 months of their diagnosis. And my project really focused on this implementation of the routine screening, thinking both about inpatient and outpatient pathways. This is a timeline of my project and looking both at kind of some baseline data collection as well as the actual implementation of the routine screening measure. So I first started with collecting baseline data, so looking at patients who were first seen within our IBD center between January of 2018 and December of 2019, so 2 years prior to our intended implementation of the screener. And really looking at, for those patients who were seen within that for the first time in our center, how many of those patients were able to get connected with a mental health provider or psychosocial provider, and what percentage of those patients were able to receive accommodations in school that were appropriate. And this process really of narrowing down the population and being able to establish kind of who these patients are took a little bit more time. It was a little bit more complicated than I anticipated, and took really close collaboration with my data analysts to really hone in on patients who have an IBD diagnosis, and to look at the first time that that was documented within our EHR. So we have what I'll be presenting today is really some baseline data from that period of time. Of course, a lot of things, oh, can we go back a slide? Thanks. A lot of things happened around the beginning of January, beginning of 2020, and so the implementation of the routine screening measure was delayed a little bit. And so we did start that about, oh my goodness, almost a year ago at this point, but I have yet to kind of look at the effectiveness of that intervention, but I'll speak a little bit to that at the end. Next slide. Okay, so looking again at that baseline data, the cohort that I'm talking about here is really patients who were first seen within our IBD center between January of 2018 and December of 2019. There were a total of 269 patients that were coded with an IBD diagnosis for the first time in that time period. 15 of those patients ended up not actually having IBD based on my manual chart review, and about 19% of the patients were actually seen here for a second opinion, and we weren't thinking about them as established patients, and so we excluded them from our study. And so the baseline cohort was really a sample size of about 204 baseline patients. Of those patients, the majority were identified as male, and the majority were diagnosed with Crohn's disease. 67.6% of our patients identified as white, the majority identified as non-Hispanic, and the vast majority identified English as the preferred language for care. So what you're looking at here are some P charts, and what these charts are showing on the y-axis is the percentage of patients that met some criteria. And so for the purpose of these two charts that you're looking at here, you're looking at the percentage of patients that had a psychology evaluation. On your x-axis, you're looking at individual months over that 2-year period. So each data point that you see, each circle or dot, is indicating the percentage of patients in that month that received a psych evaluation. So on the left side, you're looking at patients that were again seen for the first time within a 2-year period, and at any point following their first session or the first appointment within our center received a psych evaluation. What you're seeing is just over 30% of those patients had some contact with the GI psychologist. Our goal, again, is to reach 80% of patients. On the right side, you're seeing a slightly different goal or target behavior, which is patients who received a psych evaluation within 3 months of their first first appointment in our IBD center. And that percentage is a little bit lower. So just over 20% of patients were seen by psych within the first 3 months. This next slide has 2 more P charts, but the outcome that we're looking at is a little bit different. So on the left side, we're looking at patients who had any contact with social work since establishing care within our center. It's a really similar percentage actually to patients who establish care or see psychology, so just over 30%. And the right side is the percentage of patients that have some documentation of a 504 plan. So just under 40% on average have some documentation of receiving some accommodations in school. So the baseline data is really important in helping us to kind of understand where we're starting from. And the next step was really to be implementing some routine screening. So again, this was delayed because of the COVID-19 pandemic, but we did get off the ground in July of 2020. We really focused on identifying patients who were newly diagnosed with IBD during our weekly outpatient meeting and during inpatient rounds, partnered really closely with social work to call out to families to introduce this measure and send them a link to an online screening questionnaire. And then I partnered with social work to jointly provide feedback to these families about our recommendations for resources and referrals. There are lots of things to do moving forward. Certainly, we can refine our new diagnosis identification process, which pairs really nicely with our next goal of really streamlining the screening measure distribution as an integrated part of a new diagnosis process. So there aren't these additional steps, but just it becomes a more routine part of care. And I'm really excited to begin the process of really looking at how this screening process has affected care and really work to increase, hopefully increase access to mental health resources within Seattle Children's. This project certainly would not have been possible without the support of the QI Scholars Program, the IBD team, and especially Ashley Jarrett, social worker that I partnered with to really make this project happen, and the pediatric psychologists within the Division of Psychiatry and Behavioral Medicine who have provided ongoing support, feedback, and recommendations moving forward. Thank you so much.
I'm Lindsay Morgan. I'm housed within neurology. And my project this year for QI Scholars, which I was so grateful to be a part of, is working to improve patient outcomes by advancing access to our novel neurocritical care follow-up clinic. I have no disclosures. Some background on this patient population. Children with acute brain injuries and critical illness are at risk for cognitive and psychiatric sequelae. Many children have ongoing neurologic issues after discharge that's now identified as post-intensive care syndrome. And these issues can have impairments in both physical, psychological, cognitive, and social functioning. And because of this, these patients often benefit from close outpatient follow-up. And so recognizing that we had these patients and we had a gap, we started a neurocritical care follow-up clinic in November of 2018, which is a multidisciplinary clinic of neurologists focusing on neurocritical care, social work, and neuropsychology involvement. Unfortunately, our initial data suggested that only 45% of eligible patients were being seen, resulting in many at-risk children not evaluated for significant morbidity. Our study objective was thus to improve access to this clinic, as well as to present a descriptive analysis of the needs addressed by the clinic. And with this, I came up with 3 different aims: to increase eligible patients seen in our clinic from what we assumed was our baseline of 45% up to 70% by March 1st of this year, to provide a descriptive analysis of services provided to patients with the hypothesis that those who receive follow-ups will receive referrals and tests to address new morbidities. And our third aim was to analyze quality of life outcomes. This takes in-person social work interaction, and it was due to start on March 24th, 2020. So right when COVID hit, it's now on hold, but we're hoping to start this aim this summer, and patients will have quality of life measures screened, and if they screen positive, they'll be referred to appropriate services. Our study population consists of any patient that's admitted to the pediatric ICU, the cardiac ICU, the neonatal ICU, sometime during their hospitalization with an associated neurocritical care consult. Our baseline data ran from August 1st of 2018 to September 22nd, 2019. And our intervention phases started in September 23rd, 2019, and through the end of February this year, although our work is still ongoing. Patients were excluded if they already had an established neurologist here at Children's, if they required specific specialty for follow-up, such as demyelinating, follow-up with our neonatal neurologist, if they had complex epilepsy or needed neuromuscular care. If after consultation and evaluation, there was deemed no need for ongoing neurologic care outside of the hospital, or if they did not live in the WAMI region. I mentioned that our second aim was really to provide a descriptive analysis of the patients seen in our clinic. And so out of the 158 patients that we've seen during this time, a lot of them have a variety of different interventions, such as having a referral made at that clinic visit, having an in-clinic brief neuropsychology evaluation, having therapies ordered, medications adjustment, communication with school, or studies ordered. And so out of that 158 patients, 105 or 66% of them had at least one of those interventions performed. So we know that we are having an impact on these patients. And so we wanted to, again, see if we could get more patients seen in our clinic. But we recognized that we actually had a challenge understanding our population. And patients were initially considered missed if they were deceased as an outpatient, if their initial clinic visit was canceled but then later rescheduled, or if they presented to vascular clinic. And that was because our vascular provider, although she is an NCC provider, initially we didn't have a shared mental model or resources, but this was adjusted during our baseline period. And so our actual baseline rate was closer to 66%. And I have a P chart over on the side that's showing the proportion of eligible patients with the visit that did occur. Again, you can see that our rate is around, the baseline rate was around 66%. Our total rate is over 70%. But it's still not 100%. And we know that these are high-risk patients. So we wanted to delve into the processes of care which might impact their outcome of being seen in clinic. And so we looked at whether there might be differences in patients' demographic or race, ethnicity, and language data for patients in our baseline phase that had a visit that occurred or a visit that did not occur. And the chart here shows that there were no significant differences in those different groups. We also looked at patient location to see if that might affect whether they presented to clinic or not. And the area deprivation index, which is a multidimensional evaluation of a region's socioeconomic conditions, which has been linked to health outcomes. And we didn't find any differences in those areas as well. So we wanted to do a deeper dive into why more eligible patients did not have a visit occur. So I took a stab at an Ishikawa or fishbone diagram. And those areas that are bolded are areas that really can be linked with scheduling and aspects that felt that they could be intervened on and tangible. And so we wanted to focus on scheduling as our first stab at trying to get these patients actually to present to clinic. Next slide. We hypothesized that there was a higher likelihood of a visit occurring if it was scheduled before discharge, and our data would support that. So this is a P chart looking at the proportion of appointments scheduled before discharge that had a visit that occurred. And you can see the baseline data there on the left. And overall, around 90% of patients, if they had an appointment scheduled before discharge, ended up having a visit that occurred. Next slide. And so we started with a variety of different interventions, but they were really too dependent on communication. Specifically, the different solutions that we came up with were dependent on providers talking to other providers. And we recognized that this was a significant problem when COVID hit. And we saw that our rates of eligible patients scheduled for an appointment prior to discharge drastically decreased when we weren't all face-to-face in the hospital. So we had some ideas for different interventions, but knowing that Epic was coming, we put some of those on hold until Epic went live, and then implemented a hardwired intervention of a discharge checklist within Epic, as well as a dot phrase within our notes to try to get patients scheduled prior to their discharge. And you can see that since that has been implemented on the far right, our rates have been steadily above the baseline to improving. We also hypothesized that a longer length of stay might be associated with a higher likelihood of a visit not occurring. These are complex patients that often are in the hospital for weeks to months, and they may be in the ICU for a proportion of that time and then get transitioned out, oftentimes not to the neurology service, but to other services in the hospital, and don't have active neurology issues going on all the time. So we recognized that for every 1 week longer length of stay, there was an associated 3% lower odds of a visit occurring. And for every 1 month longer length of stay, there was an associated 11% lower odds of visit occurring. So we know that our ongoing interventions need to be applicable or target patients with longer lengths of stays. So ongoing work and future directions are to continue to work on these hardwired interventions to improve scheduling prior to discharge. We are standardizing language in our last neuro note regarding follow-up. We're finalizing our neurocritical care website. This has been a work in progress for over a year and a half, but we're hopeful that this will provide a resource to both providers as well as patients about this clinic and our service in general. And then to really work on aim 3 of implementing those quality of life questionnaires through MyChart and getting social work back into our clinic. Overall, this project has really been a bundled intervention approach, as we recognize that no one factor is most identified for lack of follow-up. And I really couldn't have done any of this work without a huge team, of which I want to specifically call out my QI Scholars mentor, Arthi Desai, as well as our neurology CRA, Jackie Liang, our analysts, our statisticians, and our neurocritical care providers. Thank you.
I am really happy to be here to talk about my QI Scholars project, which was standardizing inpatient care for infants with faltering growth. I have nothing to disclose. So we'll go through some quick background as well as the project development and some preliminary results, and then I'll end with our next steps for the project. For some quick background, as a pediatric hospitalist, we take care of a lot of babies with faltering growth or failure to thrive, and it can account for up to 5% of all pediatric admissions. We know retrospectively that the vast majority of these cases are due simply to inadequate caloric intake. The baby is simply not taking in enough calories to gain weight, and there is not actually an underlying disorder that is causing that. For that reason, there's a low value to getting a big panel of screening labs or diagnostic tests, and only about 1% of those labs actually help suggest a diagnosis when they're obtained. We also have a lot of variation in our care for these babies, and that can drive confusion for families, trainees, and our partners in primary care. And finally, we know that the timing of admission matters in terms of length of stay and cost. We know that babies who are admitted over the weekend have a longer length of stay than babies admitted during the weekday, likely due to the availability of PTOT, nutrition, other kind of ancillary teams on the weekends at some centers. In 2017, the National Institute for Health and Care Excellence published the first clinical guideline for care of babies with faltering growth. And they looked through a variety of clinical questions and did an exhaustive review of the literature. And the guideline really focuses on your history and physical being your primary tools for figuring out what's going on and how to get babies to grow. They also led to a name change for the term, kind of taking away the more pejorative language of using the word failure to describe these babies when we actually know that their parents have often desperately been trying to get them to gain weight at home. So the global aim of the project is to standardize and improve care of infants with faltering growth admitted to Seattle Children's. This is a key driver diagram. We are just going to focus on a few of the drivers at the top, really looking at how we can expedite evaluation by our infant feeding therapists, lactation, nutrition, and social work shortly after admission to hopefully decrease length of stay. This is a brief overview of the project timeline that I'm not going to go into a great deal of detail about, but we have done a lot of educational interventions since the pathway has gone live to try to spread information around the center about how we're taking care of these babies. And this is just a brief picture of the CSW pathway, which is available on Child and on the external CSW website. Our study population is babies who are 0 to 12 months old admitted to general medicine services at Seattle Children's for evaluation of faltering growth. We excluded babies from the analysis if they did not meet criteria for failure to thrive based on their growth chart data, if they'd been admitted for failure to thrive before, if we already knew why they had faltering growth. So for example, if they had a large VSD and we knew why they weren't gaining weight, we excluded them from the analysis. We also excluded babies who were critically ill and required ICU admission. Our primary outcome measure is length of stay. We have looked at a variety of process measures, some of which are listed here, and our balancing measure was 30-day readmissions for ongoing faltering growth. We're going to focus on a few of these measures today. So to go through some preliminary results. To date, I have analyzed close to 400 charts for the project, and you can see that over half of them have been excluded from the analysis due to those criteria we outlined on the previous slide. So a total of 176 patients are currently included in the analysis. Next slide. For quick demographics, a little more than half of the babies are male. They are about 15.5 weeks on average at admission, but you can see the standard deviation is quite broad. And they have a Z-score that averages negative 2.5 at the time of admission, so fit the criteria for moderate malnutrition. Most of them come in through the emergency department, and about 8% of them prefer a language, families prefer a language other than English. So this is a X-bar chart looking at length of stay. So the y-axis is average length of stay, and then on the x-axis you have quarters, so over time. And the red line denotes when the pathway went live. So our average length of stay, unfortunately, has not significantly changed since the pathway went live. It's about 4.3 days. We are pretty reassured, though, that we're seeing the data cluster more tightly to the mean line since pathway go live, which can be a sign of early change, and we're hopeful that we will see length of stay start to decrease a bit as we analyze more charts. This is an S chart that accompanies that X-bar chart. This is looking at standard deviation and length of stay as a function of time. We have a couple of big outliers you can see from some babies who had very, very long lengths of stay compared to the rest of the population. But again, we are seeing those numbers a little bit more tightly around the mean since pathway go live, which can be a sign of change. So one of the primary interventions for these babies is having a evaluation by our fabulous infant feeding team when they come into the hospital, who can identify mechanical difficulties with feeding, try different positioning techniques, et cetera, to really figure out how to get them to take more calories. So this is a P chart looking at the percentage of babies who are seen by PTOT within 24 hours of admission. As a caveat, this is just looking at babies who are admitted Sunday through Friday. We excluded babies admitted on Saturdays since we don't have infant feeding therapists in the hospital on Sundays. They cannot be seen within 24 hours. We're really excited that post-pathway go live, we have increased the percentage of these babies being seen within the first day of admission from 73% to 94%, and we're hopeful that that trend will continue. When we developed the pathway, our social work partners developed actually a specific assessment tool that they use specifically for admissions for babies with faltering growth. And our hope with this was that we would reduce bias by doing this. We wanted all families to receive this social work assessment to identify things like food insecurity, transportation issues, childcare issues that may be contributing to difficulties getting the babies to gain weight. This P chart shows that we have a lot of work to still do there, and still only about 30% of patients are having a social work assessment within 24 hours. So we'll be doing some additional work on that this year. Our balancing measure, as I said, was readmissions. This is a P chart looking at the percentage of patients with a 30-day readmission since go live. And you can see that about half of the values on this chart are 0 because readmissions are overall quite rare in this population. So we moved to a rare event chart for this metric instead. So this is a T chart. Just to orient you, the desired direction of change is up. So the higher the data points are, the better. This is looking at days between readmissions. So for those of you who work at Seattle Children's, this is how we look at serious safety events also. It's days between. So higher numbers are better because it means that you've gone a longer period of time between your rare events. So post-pathway go live, we have had a couple of time periods where we've gotten close to like 300 or 350 days between readmissions, which is great. We did see some readmissions cluster more closely together in the COVID time period last year. And so we're trying to look a little bit deeper into those charts to understand whether there were barriers to outpatient follow-up with feeding therapy, for example, or other reasons that those babies may have needed to come back into the hospital. However, overall, we have not seen a significant increase in readmissions since pathway go live. So for next steps, we're going to be diving deeper into ways that we can hopefully drive down length of stay. Next slide, Lynn. And really, I want to focus on increasing how many of these babies come into the hospital as direct admissions. Going back to that information at the beginning about weekday admissions having shorter length of stay and cost, the ideal state for these babies who are stable in the outpatient setting would be to bring them in first thing in the morning when we can really coordinate all of those evaluations happening on the first day of hospitalization to really come up with a good feeding plan right away. So we're going to be doing some work to look at our direct admission process for these babies, and then hopefully do some surveys of PCPs in the community to figure out what barriers there are to direct admissions of these babies in the current state. And looking at just our preliminary data, the length of stay for babies who come in via direct admission seems to be about half a day shorter than the ED admission babies, although as you can see, there's still a pretty broad range. Next slide. And lastly, I'm really excited that we have received some additional funding from our Clinical Effectiveness Research Fund to do additional analysis of this data set with an equity lens. So we're going to be going back to the original data, looking specifically at race, ethnicity, language of care, and insurance status as different variables to figure out what inequities exist in our care of these babies and how we can improve upon them. We're also going to be doing a deeper dive, as I said, into those social work assessments and trying to figure out additional ways to reduce bias and make sure that all families are having access to services when they're admitted to the hospital. This is only a fraction probably of the people who helped with this project, but I'm so grateful to the CSW and clinical effectiveness teams for their help with this. The QI Scholars Project has been so valuable in moving this project forward, and my colleagues in the Division of Hospital Medicine. Thank you.
All right, Katie Casimir, thanks, scholars. Amazing work, especially during a pandemic and new EHR. Good point. Thank you so much, you guys. Okay, and I see a question for Emily Hartford from Otero Flowers. Excellent project. With this topic and issues like people's pain scale numbers being neglected if they're not using English, how do you separate out what's a language issue versus a racism issue, i.e. some providers just not wanting to treat immigrants of color?
Yeah, great question. I think there is a lot of overlap. Obviously, they're often sort of, mixed together in terms of the bias that those patients might encounter. It depends on the study. I think in reading the literature, sometimes the race and ethnicity is actually controlled for, and they try to separate out language specifically as a variable that's impacting the outcome they're looking at. And sometimes it's more mixed together, and it's hard to separate out. One big problem across institutions is we don't do a great job at standardly collecting race and ethnicity data and language preference data. We're, I would say ahead of the curve in my experience with other institutions here, and how we collect it, asking families for their preference and asking families for their how they want to list their race and ethnicity. But the data, it's hard to actually get to the root of that question. I think there's a lot of overlap, and it depends on which paper you're reading, how they try to approach it.
Hi, Dr. Quinn. Thank you for being here. Nice presentations. Thanks to you all.
I love the program on IBD and what I've seen. The question was, in trying to get access to these IBD patients, was there ever a struggle, since there's only one social worker and one therapist, psychiatrist, to see them, like to get them an appointment? That was that ever a barrier since you were piling on more work with the screenings to yourselves?
Yeah, great question. So, what we were hoping to do, or maybe I should back up a little bit. Our original way of getting patients in were to schedule them with me for a full diagnostic evaluation. So, a big evaluation, and the wait list for that is quite long. And so, the hope with this a routine screening was to actually collect a bunch of background information ahead of time. And so, with that screening measure, we actually collected information about family structure, family stress, patient mental health concerns, family mental health concerns, and resources. And that allowed us to actually get a really good sense before we even met the patients about what they might need, which meant that we didn't actually have to do a full evaluation when we met with these patients, but could really streamline that process. So we actually were able to get patients in sooner because it was really just a quick feedback session as opposed to like a big intake appointment for which the wait list was much longer. So you're right. There were more patients that were being seen, but the visits were a little bit more streamlined, which allowed us to see more patients in a shorter amount of time.
Thank you, everyone, so much for being here. Lots of comments in the chat about thanks to you all for this great program and all the work that you're doing. And we really appreciate all of you for being here and our participants as well. And we'll see everybody next week. Thanks again, you guys.